Hey, everybody. Welcome to Resiliency Radio, your go-to podcast for the most cutting-edge insights in integrative and functional medicine. I'm your host, Dr. Jill, and with each episode, we dive into the heart of healing and personal transformation. Join us as we interview renowned medical experts, thought leaders, and all kinds of interesting people who share their journey to optimal healing and what they've learned and the science behind it. Today, in just a moment, I will introduce our guest, Brian Tuckey, who is one of the developers in the Jones Institute and does Fascial Counterstrain and teaches many practitioners this incredibly powerful science. You'll want to stay tuned if you have chronic pain, chronic inflammation, or just some unexplained mysterious symptoms that you haven't been able to improve. You might find some very interesting pearls in this episode, so stay tuned. Before I do, I just want to mention that if you are looking for high quality, verified, certified products that are clean, you can look no further than drjillhealth.com. That's DRJILL health.com. We have curated a set of incredible products and things to help you perform your best. And every once in a while in the beginning of the show, I will share one or two things that people have been really liking. Today, I wanted to share with you this new beauty collagen. This is one of my favorites. I throw this in my coffee every single morning. What I love about this is all the talk of collagen, right? You can get the benefits of collagen with this, but you're also getting all the things for optimal hair, skin, and nails in with your collagen. That's why this one is my favorite. It has silica, biotin, collagen peptides, and all of the things to strengthen your hair, skin, and your nails. I like the powder. I put it in my coffee every single morning, and that way I know I'm getting those nutrients. If you don't like the powder and you want to just get a capsule, the equivalent, very similar, is our Biotin Plus. These are capsules you can take 2 a day and have the same outcome. And pretty much universally, when patients start taking these within 30 days, they notice strength in their nails, in their hair, the breakage stops, and there really is a pretty important transformation when you get those nutrients that your hair and skin and nails need. So either the Dr. Jill Beauty Collagen at drjillhealth.com or the Biotin Plus, and you can get either one of those there on the website. Okay, let me introduce our guest. Our guest is Brian Tuckey. Mr. Tuckey is a board-certified orthopedic specialist and founder of Counterstrain in Frederick, Maryland, specializing in complex cases. He's a graduate of University of Maryland School of Physical Therapy and trained under Dr. Lawrence Jones, the creator of strain and counterstrain technique. He became one of only 4 physical therapists certified to teach it. He now teaches hundreds of practitioners across the U.S., and you will learn all kinds of interesting things from him today. What I really love is his science-based approach to something that years ago we didn't understand. We just saw it working, and he's just taken it to the next level in publishing, especially a top-ranking article in Frontiers of Musculoskeletal Pain, 2021, one of the most downloaded articles from that journal ever of all time. And he was featured in Tony Robbins' best-selling book, Life Force, and has treated himself and really brought a new awareness to fascial counterstrain. So join me as I interview Brian Tuckey. Hey, Brian, I am so excited to be here with you. I have heard about you from Chris Foz, who is in my office doing what you taught him. And I'm so excited to introduce this topic. We have listeners of all types, as I just explained to you, lots of patients, but also lots of clinicians. And I think this fascial counterstrain that you've developed and really honed into a whole discipline is so important. Before we go into that, why don't you tell us a little bit about your story? How did you get into learning about counterstrain? Tell us a little bit about your journey.
So yeah, I would say, I grew up with a, interest in medicine. My mom was a nurse. I actually wanted to be an orthopedist initially. So I decided to kind of moonlight my way, through med school as a PT. At that time, you could get your PT degree with a bachelor's. So that was going to be my degree. In the process of volunteering to get into PT school, you had to do hours. And whether it was, luck or God's providence, I ended up, going up the street to, Perry Hall Physical Therapy. And it turned out that the guy there was a high-end osteopathically trained physical therapist. So I'm watching this guy treat, and people are like, limping in and walking out and just, singing his praises. And I'm like, wow, this is really cool. So I went and volunteered at a few more places, and they weren't doing what that guy was doing. They were doing TheraBands and bikes and ultrasound and hot packs. So I went back to him, not really realizing what I had seen. And I said, I said, how come you're the only one doing what you do? And he's like, well, I'm not doing PT, I'm doing osteopathic medicine. So before I even got into PT school, I already kind of was like, wow, that's a superior method. Does that make sense?
Yes.
So anyway, he's like, if you get in, let me know, and I'll tell you, who to train under from the very beginning. So, I kind of fell in love with the idea of then being a manual therapist. I talked to a couple physicians who really dissuaded me from going into medicine. The one guy, he was just like, yeah, if you're my son, I would tell you not to go in. Managed care is hitting the whole thing. Yeah. So this was, 1989. And then, went ahead and, graduated, and he pointed me in the direction of some of the real classic osteopaths, and one was Dr. Jones. And he was the inventor of strain and counterstrain. So had tried various forms of manipulation, muscle energy, the pop and crack stuff, high velocity that most people know, trigger point work, Travail, and the carryover wasn't great, meaning, you could loosen it, but it came back.
Yes.
So I had this big stack of diplomas at about a year and a half out, saying I was, this expert manual therapist, but my patients didn't agree because a lot of them weren't getting better. And so then I heard about Dr. Jones, and, he was literally taking these restrictions and going into the direction of ease. Yeah. And so he wasn't manipulating, stretching. It was the position of comfort, which obviously was completely opposite of what I was doing. And I'm like, hey, this guy's either onto something or he's a loon. Either way, it'll be entertaining. But by the end of the class, he really didn't have a lot of fizz, behind what he was doing. But every place on my body, because I played a lot of sports growing up, where I had chronic pain, I had his diagnostic tender points. Just the work my lab partner did on me had lasting benefit when I left that class. I went back, and one of the first people I tried it on, again, these were a paradigm where there were just tender points without any anatomical correlation, which I've added today. Yeah. But he had what he called his anterior T9 and T10, which were two tender points adjacent to the umbilicus that I know today are the collateral ganglia, the sympathetics of the gut. But we didn't know that at the time. So I had a patient who was, not making a lot of progress. And I said, hey, can I try this new technique on you? And she's like, sure. So I found those two tender points. They were severe, took me probably half the session just to release those two. That's all I did, really just one, we call it stack, right, left. And she came back, a few days later, and she said, I don't know what you did last time, but it was phenomenal. And I said, what? She goes, all my back pain's gone. She goes, I hadn't had, an ounce since I left. And I said, okay, well, I guess I'll discharge you. And I said, so can I tell your doctor that you're 100%? And she said, no, I'm better than 100%. I'm like, well, how was that? She goes, I also had chronic constipation for like 5 years, and my bowel movements have been regular since I saw you. So I look back in the notes, and Dr. Jones, I had taken notes under that dysfunction for chronic constipation as well. Wow. So I was like, all right, this guy, he knows
something going on here.
so yeah, at that point, I studied with him extensively, and I became, by 1997, I was one of his 4 original instructors. So, and I compared it to everything else I was doing, and it just, even though it was early, it still was superior to everything I did. So that's really where it started. And then when he passed away, I kind of took over the reins of development at the Jones Institute, and for the last 25 years have been progressing the technique from originally 200 releases to now what's over probably 1,200 different techniques. Yeah.
Yeah, wow. And because of Chris, I hear the latest stuff and like adipose classes, and I want to dive a little bit into all this.
Sure.
Develop, because it's so amazing. And I want to kind of give the listener, like, what is this? What is it? Like the bare bones. But interestingly, I have to tell a quick personal story. Sure. So I grew up with my primary main doc that we saw was a chiropractor, and it was the same thing. And it was great. He taught me nutrition, but before we go to the pediatrician, we'd usually see the chiropractor. And it was my first intro to how nutrition and movement and everything was so crucial. So I actually came to allopathic medicine with a much more holistic bent. But like you said, what I noticed is I'd have to go back every week or two, right? Because these adjustments or whatever would happen, none of that would stay. I'd always get out of it. And in hindsight, I probably was slightly hypermobile, which also, as you know, plays into that. And the second thing is my guidance counselor in high school convinced me to go to Doctor of PT school. Like that was the thing that when I graduated high school was the biggest like up and coming thing. So I almost ended up in PT school. Not
Yeah.
have been a great thing, but it's funny because those two things in my history kind of align with some of the stuff you've been through. So let's just, for the listener or the doctor who wants to make referrals, what is this? Like what's behind? I know like fascial planes are so crucial, and that's something we were not taught in medical school, right? The anatomy, like we did dissections through fascia, but we never talked about the function. So give us a primer on why this is so critical to health.
Yes. So, basically this is something I typically will do with a PowerPoint presentation and got, diagrams and arrows. So it's a little of a bit of a challenge to do in a podcast, but let's just first realize that, fascia, we now know is the most important proprioceptive organ in the human body. So it's not inert. Okay. So, when you and I went through school, it just basically gave us, contour and held us together, but it's a proprioceptive organ. So it has, nociceptors, which are pain receptors, has mechanoreceptors. It is also contractile. So there are myofibroblasts, which are little smooth muscle cells that are in all fascia. So what is fascia? Well, any soft tissue. So your ligaments, your tendons, the covering of the muscles, the visceral ligaments, the tunica adventitia of the vessels, it's all fascia, the meninges and the dura.
Yeah.
So it is a proprioceptive, contractile organ that is really, one of the most important things in the body. And again, it's ubiquitous; it's everywhere. So the first thing when you start to treat fascia, you have to realize it's inherently a multi-system paradigm. So there is way too much emphasis on myofascia. Okay,
Right.
so it's like myofascial pain syndrome. But if you look at the proprioceptors that are in it, you should say, well, this could be, visceral fascial pain. It could be vascular fascial pain. It could be ligamentous pain, capsular pain. They all have nociceptors. And much of it presents like musculoskeletal pain. So you don't realize that it was a, parietocecal ligament of the colon that was actually inflamed. So now, again, trying to go through some of the base phys that we can, unwind later. So the question would be, and this is where the first article came out, what can make persistent chronic pain? Okay, so we know if you have an injury, it heals and that pain goes away. So how can you have ongoing nociceptor activation, related to these different pain receptors and the different types of fascia? And the answer is it has to be chemical.
Mm-hmm.
So inflammation, which we all know is the root of a lot of a chronic disease, can actually get trapped in the interstitial space, which is the microvascular system. And the way that happens is you really just need a significant production of cytokines or inflammation. So that can happen with trauma, that can happen with surgery, whiplash, overuse, immune reactions, post-COVID, post-Lyme, all produce cytokines. When you get a lot of cytokines in one area, particularly 3 cytokines, and by the way, you'll have links to this, I'm sure, but if you're a physician, this entire conversation we're having here is a published rationale in 2021 in Frontiers of Musculoskeletal Pain. It's 6,300 words, 147 citations to really describe this.
And we'll be sharing links. So if you're watching, if you're in your car, don't worry. I'm going to put that in the show notes.
Yes. And the article is the other kind of chronic pain models that are out there. Several of those doctors are on this paper with me, so they've endorsed this model now. It for the very longest time was the number one most downloaded article in that journal all time.
Wow.
So anyway, it's not junk science. So, but I'm going to try and make it an audience discussion here. But if you really want the citations, get the article. Anyway, so you have a cytokine exposure, and the chronic pain studies show that 3 specific cytokines were associated the most with chronic pain states.
Yes.
And that's interleukin 1B, interleukin 6, and TNF alpha. Okay?
I knew IL-6 and TNF alpha would be on there because on my realm, I'm monitoring these and seeing the association with depression and with gut issues so it makes perfect sense.
You got it. So like if you start to look at the CNS research of inflammation, what's elevated in the CSF, et cetera, same thing, right? That's the same, the big 3 I call them. So that was my clue as to, what could be, look into those 3 cytokines and see if I can figure it out. So they all cause pain, and there are many pro-inflammatory cytokines. So yes, they can cause pain, but those 3 specifically, it turns out in 2013, researchers found that those 3 shut down the lymphatic pump mechanism. So why would the body do that? Well, those 3 are very commonly produced in infections.
Yes.
Okay, so the body doesn't want to spread the infection, so it initially shuts down the local lymphatic pump. So now, the war can be waged and the macrophages come in, T cells, B cells, but they produce more cytokines. Well, it turns out if you get a lot of those same three, they will make fibroblasts, which is the fascial tissues, turn into myofibroblasts and produce TGF beta 1, which causes contraction of all fascia.
Wow.
So now you get in the pre-lymphatic channels, of the lymphatic system, which is also the new interstitium they discovered in 2018. All this clear fluid that envelops nerves and is in the pre-lymphatic sheaths of the vessels and the muscles. That tightness now occurs and traps those cytokines in the pre-lymphatic space. So now you have what I termed interstitial inflammatory stasis. So you have to understand this is an area of non-movement of the lymphatic system. Those nociceptors are now chronically firing.
Yes.
The tissue's contracted. There is no lymphatic flow, and it's not even in the bloodstream. It's in the clear fluid, the blister fluid, the interstitial fluid. So that's why it's you take, medications and things. It can go through the bloodstream, leaches into the interstitium, but to get into an area of non-flowing, you following? It's not going to happen. So then you say, okay, we got stasis, but what happens? That's where the magic occurs. When you get an activated group of nociceptors, which again, these cytokines will stimulate the pain receptors in any tissue, that signal goes into the cord, dorsal horn, and can give you chronic pain, okay? And since it's trapped, it can make a loop. But here's where it gets interesting. So those nociceptive neurons go into the ventral horn as well. So you get muscle guarding reflexes. So now you get the trigger point.
That's how you see, like your vision is through the palpation of those. Wow. I just have to pause for a second because my brain is just, there's so many ahas, because here I'm seeing Bartonella, which massively affects lymphatic drainage. And I'm seeing mold-related illness, which almost always results in a TNF alpha elevation or TGF beta elevation, and it's chronic. And now I'm putting that all together because, of course, those toxicities create massive dysfunction in lymphatic drainage and liver function, which when the liver is overloaded, it dumps into the lymphatics. Right. And so on my side, I'm seeing these in markers and consistent elevation in my patients because I'm checking that and they're having the pain and the symptoms and all of that. So keep going. But I just want to say, like, from my perspective, I see this all the time. And I did not realize all the underlying mechanisms that you just described.
Yeah. And the basic paradigm, which, I'll go into a bit more, initially did not include the lymphatic system. But I've been lecturing on this model for about 20 years, but, some of the key articles, for example, that you can drip TGF beta 1 on healthy fascia and it contracts. That was 2019. The fact that the lymphatic pump shut down, that was 2013. The fact that, once you get this stasis, they have now seen these sclerotic pre-lymphatic and contracted pre-lymphatic channels as of 2020 in acquired lymphedema. And the interstitial sampling studies, okay, they've gone into trigger points. Actually, Dr. Jay Shah, who's on the article, he's an NIH world-renowned researcher. But anyway, I told him back in 2007, I was able to help him with his chronic pain. And he's like, what are you doing? And I said, I'm draining trapped inflammation. And he said, yeah, but no one's ever said that exists. I'm like, well, no one's ever tried.
Right.
So he and his team, made a microdialysis needle. And they went in and measured, the cytokines or basically, inflammatory mediators in active trigger points compared to an area with no trigger point. So like upper trapezius, out.
Like a placebo trigger point, right? Like
exactly. So same person, but like the painful one and the non-painful side. And they were elevated in 23 different chemicals. So it would prove there was trapped inflammation in the trigger point. So that was what they call interstitial sampling studies. So the point is, all this has been out there, but no one ever put it together and say, so, okay, what makes persistent bombardment of that dorsal horn? So anyway, long story short, you get the pain from the chemicals stimulating the pain receptors. Alpha motor neuron fires, contracts the joint, so it's now protective state. So you get the trigger points, the ropiness, the loss of range of motion, the segmental restriction, whatever you want to call it. But here's where it gets even bigger. Those same nociceptors go into the intermedial lateral column and cause sympathetic nerve activation. So the sympathetic nerves at that level fire. Well, what do? They cause vasoconstriction.
Yes, let's shut it all down.
Right. So now you get poor blood supply in, no lymphatic drainage, and poor venous drainage. So you'll have hypoxia. So you can get, over time, if you don't fix this, you get degenerative changes.
Yes.
So you talk to the person who hurt their knee in football, and 20 years later, that's the knee that degenerated because this nociceptive loop with vasoconstriction, no one ever fixed it.
Yeah.
So now you have chronic vasoconstriction and you get degeneration. Do you follow me?
Yes.
So the point is, you can now take that same vasoconstriction and also look at organs. So if your T6-7 segment is dysfunctional, you can get, a hepatic artery. You can get, the portal vein system, or any of those same segments become dysfunctional with a bit of a vasospasm, and you get all these idiopathic pain syndromes and weird organ stuff and irritable bowel.
Like you said, the end organs are affected because of blood flow or because of.
Correct.
Yeah.
Correct. So you might see that as a dysfunctional organ, or your enzymes are off, and you're looking for pathology, and you don't see it, and it's just a nociceptive positive feedback loop that's driven by peripheral trapped inflammation.
Wow, this is so fascinating because I'm thinking of, even with a blood flow restriction, again, I do a lot of environmental toxicity like mold and infections, with both of those exacerbate these syndromes, and TGF-beta is up, and VEGF, which is new capillary formation. I often see that up when there's this problem with diffusion to those peripheral little areas, and it probably is affected by this because it's clamping down on the blood flow because of
and the body's trying to revascularize.
Yeah, exactly.
So that's the basic, peripheral model. And again, this could be the whole paradigm of fascial counterstrain. It's a complex process where we identify where that trapped inflammation is. So that's all the assessments we do.
Okay.
And if you've had some of it, it's some weird test that I've developed. But we find it.
Amazing. Yeah. Well, first of all, I have to say, you are a genius in this field for going into this and then going deeper than Dr. Jones and going further, because it really is a new paradigm, and it's so science-based. That's what I love about the research you brought. And it's helping people like nothing else. I mean, we've always had myofascial release and craniosacral. This is different. Do you want to kind of describe why this is different?
Yeah. So it's different in several ways. Number one, these techniques that are even myofascial, they're not really diagnostic in the sense they feel tightness and they just try and unwind it. And you don't know in that particular paradigm, is that a primary or a secondary area of tightness? So again, this gets complex, but you can understand the basics of it. As of 1990, they started to realize what's called the dorsal root reflex. And that is, if you have a source inflammation like we described, when it sends that inflammation into the dorsal root ganglia, then there's a shooting out retrograde of inflammation to that whole segment. So a lot of the tightness and a lot of the tenderness is secondary.
Yes.
So when people start just getting in and digging around, they don't know where the primary stasis is. If you identify the primary stasis, release it, everything goes away, and it stays away. Okay. So the process that I developed through the diagnostic tender points, various motion tests, including through the cranium, it tells us where the primary stasis is, not the secondary neurogenic stuff. So we can find the source. And then we drain that with our hands, literally decompress it, unload it, and just hold it there till it drains, which takes about 45 seconds. As a patient, it's completely backwards from everything you've had because it's painless. We unload it, decompress it into this kind of that feels good position, and we just hold it till it drains. We do not engage the barrier. We do not cause pain. We drain out the swelling that's driving the loop. Once that interstitial cytokine concentrations drop, well, then all the reflexes reverse. Pain drops down, muscle guarding relaxes, vasoconstriction turns into vasodilation, it flushes, and it clears it. And we drain it into the lymphatic system, you end up, venous system, you pee it out, it's gone. So when you do it right, you're doing it at the highest level, every release is one and done. You don't do that release again. Okay. They'd have to be completely re-injured. Okay.
That's amazing. I'll just tell you again, I've had experience just getting it, so I'm not the expert you are, but I had a fractured radius here a year ago, and I was having swelling and constriction, because of I had hardware in there and everything.
Sure.
When Chris treated me, he's treating the opposite wrist because it was a reflex loop, right? And again, you'd understand this, not me, but it was so weird. But all of a sudden, when he treated this perfectly good right wrist loop, and all of a sudden the swelling went down, I could wear my watch again. I had no more neuropathies in my fingertips, and it was always like, wow, that's so amazing.
How that happens. Yep.
right? It's the cervical loop that goes about down both arms to that place.
Right, because the CNS. We'll get into
Yeah.
the complexities that you're talking about in your caseload. That's the world I live in now. I
Yep.
take predominantly head injuries, TBIs, POTS. That's what I live in. But we're trying to talk about like the sports medicine example,
Sure,
right?
sure.
So again, it works in these areas of peripheral pain, back pain, neck pain, tendonitis, dot dot dot. But where it's exciting is
Mhm.
that when you get someone, and the functional medicine doctors will know what I'm talking about here. You get these people with this multi-system dysfunction. So they've got digestive dysfunction. They've got, cardiac symptoms. They have chronic pain. They've got, muscle tension throughout their body. And you send them to the GI doc, you send them to the cardiologist, and they're like, there's really no pathology here. And you're like, how could this person have this much going wrong with them? Well, where the exciting stuff is that you have to realize this inflammation can get trapped in the area of the brainstem. So,
Okay.
for example, inflammation in the upper cervical area of like the emissary veins and epidural complex can inflame the medulla. So the medulla alone, okay, at the very bottom, you have your dorsal reticular nucleus, and that's a chronic pain nucleus. Go up a tiny bit more, you're looking at some of the nuclei of the cranial nerves, like your glossopharyngeal, and hypoglossal as well. So hypoglossal, if you stimulate that one, it causes retraction of your tongue. Well, what's that? Sleep apnea. Okay, go up a little higher, you get into the dorsal motor vagus nuclei, nucleus solitarius, nucleus ambiguus, and then the rostroventrolateral medulla, which is the entire parasympathetic and sympathetic nervous system.
Wow.
And then you go up a little higher, you get into the reticular formation and you get into muscle tone. So just the medulla could give you just a myriad digestive problems, heart problems. You can have muscle tone problems, chronic pain, and it's just one area of inflammation.
Wow.
So that's why I say to my students, in those cases, you got to look upstream,
Mhm.
not downstream.
That makes
You
so
know?
much sense. And
Yeah.
let's talk just briefly because I have a ton of patients with the whole triad of mast cell activation and POTS dysautonomia
Yes.
and the hypermobility stuff, which again they often present with pain syndromes and we know mast cells can aggravate, but you're saying often like the brainstem or something or
Yeah. So,
parasympathetic balance. Where would you go with that? Or do
well,
you
exactly. So we start with the lymphatics, the glymphatic system, the lymphatics of the brain, the dura, the upper cervical spine, the epidural system, and we just drain that area first. The assessment tells us, is this a central problem? Is it more peripheral or both? So we go through that. And there is, again, I keep using the word process because when you follow it, the diagnostic process, it's smarter than we are. It says, I want this first, I want this second.
got it? So you teach that kind of.
I teach the process, yes. And so the techniques are here. It's a toolbox, but what order you apply them and where you apply them, the diagnostic process tells you. Okay, and this has been, again, Dr. Jones started this back in, let's say the 1960s, and I'm still developing today in 2025. So it's very far along and it's in the brain now. But I'll give you an example of like you say, mast cell activation syndrome or someone with PTSD. Okay, well, go into the pons. So that's it's funny because people will come in and I'm like, oh, you're just the pons. I'm like, so by the area of the brain, they have classic symptoms. So there you're getting into your trigeminal nuclei. So TMD, trigeminal, chronic headaches. Well, you also have the locus coeruleus, which produces norepinephrine in the brain. So now that can end up, cranking up your whole immune system. It can end up giving you anxiety disorder. So it's like, there's this various symptoms that you'll see. You get into the midbrain, now you're into the superior and inferior colliculus. You can get auditory stuff like tinnitus. You can get, disequilibrium in the vestibular nuclei. So like these really, really messed up people are just brainstem swelling people. And, you don't chase it around the body. You fix the source, the neurological source.
Oh, that's fascinating because again, I've seen a lot of people with those kinds of symptoms, and of course, medically, I can only do so much. But that's where these manual therapies, and especially the fascial counterstrain, is just profound. Maybe share a few like interesting case studies or things that.
Yeah. Like this is where I often have all kinds of videos so you can see it. But I'll use a case from today, okay? Because my personal caseload, I'm really working on the research of those complex patients now. So I take emails, a lot of them are sent by my students, and I want to make sure they need to see me. Is it someone, that is a sports medicine? I'm like, you don't need to travel to see me. Go see Bob, he's in Texas. So anyway, so I'll use a guy that I heard you mention, mold toxicity.
Mhm.
So I had a guy, I followed up with him for the second time today, and his wife brought this guy in, and he's had for 3 years, but really 1 year. He had COVID, he had black mold exposure, and a history of a couple bad motorcycle accidents. Well, when they started, and he's working with some high-end functional docs down in DC here, but when they started to kill things off, he started to neurologically just tank.
Mhm.
And, they were like, oh, we got to back off. We got to back off. Well, anyway, he became basically a Parkinson's presentation,
Yes.
kind of catatonic. He just stares through you. His verbiage is random if he talks at all. Fascinating Parkinson's gait. The guy, she says, in 1 year, it's just not my husband. Said we were traveling the country 1 year ago. And as we've tested him, he's got all these things. But as we kill them off, he's getting worse. So she luckily went in for a visit to her functional medicine doc, who's a friend of mine, and just said, I'm so worried about my husband. She's like, all right, I've seen this before, stop and go let Brian take a look at him. Long story short, he was so congested in his lymphatic system, his venous drainage, of his brain, that as things are being killed, they're just expanding and pressurizing his cranium.
Yeah.
So I literally just said, just give me a couple hours of work here. Let me decompress everything, get the pressure out of his cranium, and then you can go back. Well, he came in today, and he no longer has any tremors. He's now speaking in sentences, short ones that are appropriate. He makes eye contact, and his gait was at least 2 times longer. He's buckling his own seatbelt again, and this was basically one session I did last week. And so I'm going to probably do 3 hours of work with him, get everything, flowing and draining, and kind of mechanically decompress him, restore perfusion. Then I'll say, go back and, work with your doctor again now that we've got things decompressed. Does that make sense?
Oh my goodness. Yeah, it totally makes sense.
So yeah, it's really takes a village. Like, I can't kill off the mold with my tool set, but you have to have an appreciation for the physical problems or the vasoconstriction. Does that make sense?
Makes so much sense, because here I
Yeah.
am, I do functional medicine, and the same thing, toxicity and mold and infections. And I'd say 1 out of 10 patients, I know there's this blockage with their lymphatics. They're just getting full and toxic. And I need people like you. We've tried lymphatic drainage, we've tried massage, some of that, but that is all temporary. It's not as powerful as what I've seen with you and Chris. And this is so fascinating, because it really is a missing piece. And it's stuff I can't do in the office, just like you said, so it's really, really powerful. How many?
And like with surgeries, it's another place. Okay, so when someone has like a degenerative rotator cuff tear, well, that's been going on mechanically and as far as those trophic changes and poor blood supply for so many years. Well, they take that shoulder and then they traumatize it in surgery. So it creates more cytokines, it creates more inflammation, and the doctor did the proper surgery, but he took a unhealthy lymphatic, vascular, and tissue area, and through the surgery, traumatized it, and it just gets worse. Do you follow me? So what you do is, yes, you need the rotator cuff repair, but you send that person for pre-op. So we unlock the capsule, we restore the lymphatic flow, get rid of the sympathetic activation, all the blood supply, and the shoulder is weak, but it now moves, it's flowing. Then you go into surgery, and the post-op outcome is so night and day different. So prep them for surgery, right? Get the surgery, clean them up. And so, we work with the medical model. It's, anyone who, you don't want to overstate what you can do, but as you already alluded, it's a huge missing paradigm and a piece of medicine that is responsible for so many idiopathic conditions. And it just makes your life easier. If you've got a true, like post-Lyme, what is that? Well, that's the leftover cytokine storm from having Lyme or COVID. You got to go in and clean up the battlefield. That's what we do.
And most of the time, no amount of antibiotics, just like you said, I see that clinically so often. It's actually very infrequent that I throw antibiotics on them unless it's a very clear case, because usually that creates more toxicity, more die-off, and they don't get better unless you're dealing with the drainage and all these pieces that you're talking about.
Right. So anyway, the kill-off protocols and things work wonderfully if the body is healthy enough to receive
Drain,
it.
exactly.
Yes. But yeah, I always say, don't flush a clogged toilet.
Right.
You got to be draining, And definitely don't do it in the brain. That's where it gets really bad.
So you mentioned this, and I think it's so critical. It's one of the things that I started with like hormones and HPA axis, some really simple stuff. And 20 years ago, people got well more quickly. But now this environmental toxic load is so much. And then when our bodies are toxic, we can't move that toxicity out. We can't clear the cytokines. But one thought here is one of the things I've seen most important in the last maybe 5 years is dealing with the limbic system, and you alluded to that because we can do all the brain retraining and all that stuff, which is great.
Yep.
The place for that, but the more important thing is probably if your sympathetic system is just on switch and you can't turn it off.
Yep.
And you talked about certain areas. Do you want to talk just a little bit about what you're seeing as far as some of the chronic? Does the inflammation drive limbic overactivation or sympathetic tone, or how does that connect?
So I am trying to get another article published that's a small PTSD pilot study we did. And we had independent CAPS 5 assessments done, 18 PTSD, first responders. Anyway, by the end of 3 sessions of counterstrain, even 6-month follow-up, 17 out of the 18 tested negative. But anyway, in that article, I wrote what's happening here. So what inflammation does to neurons is it lowers the threshold of activation.
Yes.
So if you think about pain neuron, that makes sense. The sciatic nerve's inflamed. You don't have to do much for it to hurt. Okay. But that's also true with the sympathetic neurons. Mm-hmm. So when you inflame the areas of the nuclei and the sympathetic nervous system, so your threshold of activation, meaning your stress reactivity level, it lowers. So you become hyperactive or hypervigilant. So we literally go in and drain the inflammation off of these areas and it raises back up your threshold. Wow. So these guys, like the one guy, it's profound changes that they'll come back. The wives come in and they're like, I got my husband back. He doesn't yell anymore. Because here's the real key with that. And again, we can talk about a lot of conditions, but what PTSD is when you have the central autonomic network firing, frontal lobe, hypothalamus, amygdala, it's a sympathetic, network. Well, sympathetics also stimulate the immune system. Mm-hmm. So the microglia in the brain start to produce inflammation along that pathway. Well, what that does, and it's protective, is it sensitizes the pathway. So now, like I always say, you don't want to be a great sleeper in a foxhole in Iwo Jima in 1943.
Right.
Okay? Okay, it's not a good thing. So, the body sensitizes itself as a protective mechanism. But now it's a pathway of inflammation. It has become a physical problem.
Yes.
So it's a psychological trauma that can become a physical problem. So then you can't take him or her out of the battlefield and say, oh, just chill. Right. You need to just relax because it's now a physical problem. So we go in and on the preganglionics, postganglionics, and in the brain stem, we drain all that swelling out that the body has done to protect itself, and it just kind of reboots the computer. Wow. And in the limbic system, same thing. You get inflammation in the limbic system. Basically your emotional regulation, your short-term memory, brain fog, cognition, these are all inflammatory things. Where you've got to be careful, though, is that this stuff starts out as inflammation, which makes neurons malfunction. Mm-hmm. Then if that goes on for a long time, the more inflammation, the body takes that pressurized head and it creates vasospasm of the arteries because it doesn't want to put in what it can't get out. So now you have some hypoxia. So now you can start to get demyelination. And if it continues long-term, you'll get degeneration. Uh-huh. So what starts out as inflammation eventually becomes more permanent if you don't get there in time.
So talk about, from your perspective, when we see dementia, Alzheimer's, there's like vascular, there's, atrophic hormone, but this sounds like a bigger view of this is really this process that's creating inflammation, creating lack of blood flow, hypoxia. How would you describe and I'm sure you've treated cognitive issues.
Oh yeah. Yeah. Every day.
Talk about that a little bit because I think it's a different perspective and a very valid one for subjective cognitive decline in early dementias, right?
Yeah, so let's look at the easy mechanical. We don't want to get into the aquaporin, genes and Alzheimer's and things, but which is actually what my son's a MD, PhD, and that's his area.
Oh wow!
But anyway, if you take let's look at the athletes post concussion. Okay, so what we know is multiple concussions, then there's a latency period. Mm-hmm. That's the key word. And then we start seeing neurodegenerative changes, tau protein accumulation, ... Well, think about this paradigm. Concussion, swelling, more concussion, swelling. Now you have this, between the dura and the upper neck problems, you've got this pressurized head. Well, again, the body will create artery vasoconstriction, which is a lot of like chronic fatigue syndrome, and so now you just don't have any energy neurologically, and you have pressurized headaches, and you have brain fog, and all these things. Well, latency period is you left it there. You're like, oh, just rest, rest your concussion, you'll be good. Well, no, now, 20, 30 years later, that person's brain is changing. The lymphatic system in the brain isn't working. So that's the filter of the proteins. So those big proteins can't get picked up by the lymphatic system, so they accumulate. You see? So now you start to get some physical block plus poor perfusion from the sympathetic drive plus your lymphatic system, and it just starts to accelerate. And there's just no flow through the parenchyma of the brain, and it starts to become permanent. So what we need to do is take that person who has post-concussion syndrome or post-viral brain fog and treat them now. And if I catch the person, up till, let's say 15, 20 years of that, it can basically be reversed. Okay. But there is a point where they'll improve, but parts of the brain has degenerated. It's gone.
Yeah.
And you can help them, but you can't fix them at that point.
And that's exactly what we're seeing in, Bredesen protocol, Recode, some of these protocols is the early is very reversible.
It's key. Yes.
Once you get to moderate to severe, it really, no matter what we do, functional medicine, or I'm sure what you're seeing too, there is some irreversibility of that. And it's interesting you mentioned like the Parkinson's, because we've seen a lot of Parkinsonian diagnoses that are not true Parkinson's that sound like they're reversible. Have you had multiple cases of that?
Yeah, I've got some really nice videos of it in real time. Like I have a guy who came in, about 2 years ago. He had was really more of an intention tremor. It wasn't a resting tremor, but he was diagnosed with Parkinson's, responded to the meds. They eventually stopped working and he couldn't type. And they wanted to put a stimulator in. So at this point, his wife knew of our practice and said, will you take a look at my husband? Long story short, I worked on him and a little bit older techniques than I'm using today. But in about 3 sessions, I got the tremor to stop and he was doing fine. And then he had a mild TIA about 6 months ago. And his tremor came back, and he went to his Parkinson's doctor, and the doctor said to him, well, yeah, you're on max meds. You need to get the stimulator. I told you that. And he's like, yeah, but I was gone till this TIA. And he's like, I'm just going to go back and see my therapist. And the doctor said, you honestly think that therapist stopped your tremor last time? And he goes, no, I know he did. I flew in and it came back without it. And he just kind of laughed at him and walked out. And so when he came in this time, he's like, well, you videotaped this entire session. Yes. So each release I worked on, basically I've mapped out the basal ganglia, corticospinal tract. I worked on the whole thing. And, you can see halfway through his hand stops and it's just one finger. Then I did a corticospinal tract and it stopped. Then I had him come back 3 months later and I've got the video and his hand's solid, rock solid. Wow. So he took the video back to the doctor and he was like, see, did it again. So, yeah.
Oh my goodness, I love that. I just have the greatest respect because I know my little narrow what I do, and then I see people like you. And the great thing, Brian, is you're really like you have developed. You took what Dr. Jones was doing, but your method is really what I'm just so curious as to was that insight? Was that like just really being intuitive? How did you kind of dive into the formation of what you're teaching now?
Yeah, I mean, I get that question a lot, as you would imagine. I would say there was some intuition, but also just a scientific curiosity as to, how can we really reach the maximum potential of this technique if we don't know exactly how it works?
Yeah.
And how can we mainstream it if we don't have the science behind it explained? Does that make sense?
Yes.
Now, in Dr. Jones's defense, because I've been just looking at the research, pain science, everything just for 25 years, so much of what we can now talk about to explain what we do, it wasn't available. Like the lymphatic system itself of the brain and spinal cord didn't exist till like 2017, right? So fascia wasn't contractile until, 1997 was the first one. So, this stuff wasn't available to him, but he would call it, Dr. Jones said, this is a tender points or sensory manifestations of an underlying dysfunction. Like he said, there's an underlying spinal cord thing going on here, and he knew that. So he had one article where it was Dr. Irvin Core, proprioceptors and somatic dysfunction, 1975. And it was the first guy to say, this dysfunction stuff, it's not scar tissue, it's something reflexive. Mm-hmm. And then Van Buskirk in 1990 published that it was probably the nociceptors that were driving it. So I do, by the way, have, it's in peer review right now. I have an article on the method. So it's going to be, it's called Fascial Counterstrain, a methodological advancement in indirect osteopathic manipulation. It's in a master class category in the International Journal of Osteopathic Medicine, and it's in review now. But that goes through exactly what you're asking. I basically took the Jones points and developed an anatomical correlation for each one. Now, how's that work? Because it's, again, what's the science behind that? Well, part of that that retrograde inflammation I was talking about. So the source inflammation where there's the stasis comes into the DRG, and for each deep nociceptive tissue, there's a convergent patch of skin, a cutaneous. So it shoots up a tender point to the skin. So if it's inflammation of the hepatic artery sheath, you get a hepatic artery tender point, and it's always around that same myotome, dermatome. That one actually is on the seventh rib because it's a T7 organ. So we monitor the surface, and I figured out which vector, what depth, and what it is through a mechanism I'll describe, and you fine tune that shortening until the tender point in the surface drops off. So the beauty of the tender points, it makes our diagnosis, but it also allows us to monitor the effectiveness of the drainage, because as you drain it deep, you'll start to feel kind of relaxed. The surface tender point goes away. Yeah. So it's not a random release. Right. We have a goal, which is we're going to fine tune that till that tender point is gone.
Okay. And that's my experience getting this done is like, wow, oh, that's really tender. I'll tell Chris, and they're like, and then of course he fixes it. I'm like, wow, and it's been, so again, I really believe in this, but I want to just publicly kudos to you, because you have to have a really unique ability to be very curious, very science-based. And even with me with functional medicine, I've always tried to be like, how can we get great science out of stuff we don't yet understand? Yeah. And I just have great admiration for you for what you've done, because back in the day when you started this, you didn't have all the girth of foundational science that we do have now. Now we know about the lymphatics, and we know the fascia, and we know, and you've proven but you had to start out without that scaffolding and trust that you would, and I really, really want to say how much I admire that, because it's people like you that are changing the face of what's possible in medicine. And there's so much limitation with what I do in the clinic without the manual part of it.
Yeah. And you really, what I did notice was that when Dr. Jones stopped to teach, yeah. And I met him, I did not meet the man in his prime. I'd hate for people to have judged me in my 80s. But he stopped to teach, and then the development ceased. Yeah. So, because he was just teaching. And so I said, I can't ever do that. So I've literally, up until, this is my 35th year in practice, until 2 years ago, I was still, teaching, developing at night, teaching and doing research, teaching weekends, and treating 5 days a week. I just dropped to 4 days a week, 2 years ago. Okay. So, and I'm taking that day off to work on my courses and. And
here you are giving us your time. It really is so admirable.
So it took a lot of time. Let's just say.
Yeah. I think what Chris said is anyone with manual ability, so a chiropractor, massage therapist, a physical therapist, who do you train and treat? And if people are out there listening who with a license, who could learn your technique or do more?
Yeah, so that is really why I'm starting to do the talks, because we honestly are inadequate in the practitioner world. We just are. There aren't enough of us. Yeah, okay,
exactly.
So one of the you may have seen him on the website, a big advocate. Is Tony Robbins. And so I was actually working on Tony this weekend at his house. And Tony asked years ago, he said, I'll put you on Dr. Oz. And I'm like, no, you will not. I said, Tony, we don't have anybody. He's like, well, how many people are you okay with in the United States? I'm like, 25 to 50. This was 10 years ago. And he's like, 2,500? I'm like, no, 25 people. Right. And he's like, yeah, you got a lot of work to do. So anyway, but now we have hundreds and people like Chris that, but we really do need more practitioners, and we don't need, 7 million people looking for 100 qualified people. Does that make sense?
Absolutely.
So what we need is, anybody with a license to touch, and that could be a naturopath. We have lots of naturopaths who are doing it now. In some states, even acupuncturists can do that. Massage therapists can. The wheelhouse are osteopaths, physical therapists, chiros, because they have a science background and the hands-on training. But we have, I have a pediatrician friend of mine who she fell in love with counterstrain on her own body and family, and she closed her practice, and she's a counterstrain pediatrician. So she just treats kids, and she decided to be a counterstrainer, So anyone who can legally manipulate with a license can learn.
Wow, I love this. And that is actually one of the main reasons I wanted to have you on because I've seen such a profound influence in my own life. We have someone in my office, and I'm so lucky to have him because, again, it's hard to find people.
Yeah.
And he's independent. It's just that he uses my space and I can walk down the hall and
Sure.
get treated. So it's
Sure.
great.
Yeah.
But I just have greatest respect. So if people want to find out more, and we will be sure, if you're listening, the main study that you first referenced in Frontiers,
Yes.
and also when this is published, we'll be sure and bring that out. Maybe we'll bring you on again. Where can people find you? Where can they find the training? Tell us.
So yeah, the training is through, in North America, it's through the Jones Institute. Okay. So it's just basically www. It's JI for Jones Institute, jicounterstrain.com.
Perfect.
And Foundations of Fascial Counterstrain is the first class. Okay. And there's pre-course content that once people sign up, if they're a massage therapist, we go over in class 1 the basic assessments. We give them 40 techniques in 5 different systems, including treatment of the sympathetic nervous system in class 1. So you get pieces of 5 different systems in class 1. So it's theory. We'll go through the science of it. You learn the basic assessment, and you come out with, you're treating viscera, and you're treating arteries, and you're treating ligaments, stuff that you've never done in class 1.
Wow. Yeah. So this is great. So if someone even just wants to kind of dip their foot in and get interested, they can go check that.
Yeah. I've had a lot of physician referral friends, doctors that are just like, I want to understand more of what you do. And they take Foundations. They're like, I'm not going to do it for a living, but I want to know what I'm referring and why this works the way it works. So I've had lots of people just take the first one just to know more about it.
Fantastic. And then if they do want to find a practitioner who's trained by you, is that also the site they would look for practitioners?
Yeah, so this is where it gets a little complex. So the Jones Institute, jicounterstrain.com, and again, we can put that link on there. That's for training. Okay. But there is a international website is solely related to fascial counterstrain, and it's called counterstrain.com.
Got it.
Okay. That one is one of my teachers and I own and run that website, and we won't let anyone on that practitioner search who hasn't taken at least 4 classes.
Perfect. So
the curriculum in the end is, it's over 10 classes, but you don't even get on until you've taken at least 4. So counterstrain.com, it'll default to the, who's closest to you. But I'll be honest, if you have a severe case, what most of those people do is they'll fly out to a high-level person, do like 3 days in a row. That's most of my case. I'll do 3 days in a row, and they'll fly back. And because the carryover is so good, many times that's all we do. Wow. So it's not like you got to go 3 times a week and keep coming. It's an intensive, clear to let the body do its thing, go back, and hopefully we won't need you to come back. So you may have to travel to get like work done in the brain, for example, if you had a TBI or something.
Absolutely amazing. I just have the deepest respect for you, for your work, and I wanted to be sure and bring it out to the world and share it with my little spot, shine.
Oh, no, I appreciate it. I've had a lot of, patients go back to the doctors, and even at the Mayo Clinic, like several years ago, some cases where they were stuck and they came and were dramatically different. They went back and they're like, we admit you're very different, your blood work's different, everything is different, but we've never heard of it, so it must be a placebo.
Right.
So, they're denying their own tests, and I'm like, at least you've heard of it, it's real science. It's not voodoo. Yeah.
Amazing. Last question. This is just interesting. If you could go back to your younger self when you first sat with Dr. Jones, knowing where you're at now, what would you have said to that younger version of yourself? Like, has it been a hard journey? Has it been, what?
Yeah. Oh, yeah.
Advice would you give to your younger self?
Somebody once said, you don't want to be a pioneer because they all get slaughtered.
Right.
And I've been through that. So, it's better to be come as a settler. But Dr. Jones, one thing he did say to me multiple times, and again, I was training with him at like 23. He said, once I was an instructor, he said, I want you to promise me you won't let this die with me. So he knew it was at the beginning and not the end, because he was so intuitive, that guy. So that was it. He was like, you got to promise me you're not going to quit this. And I was like, I promise I won't quit.
So
So,
you're kind of carrying this legacy of first, I mean, that's just really, really special. I just, well, thank you. Despite we had a little video troll in the beginning, but I am
yes, we
so
did.
glad we stuck with it. So excited to get this out here. And so it is JI Counterstrain for training, the foundations course if you want to know more and you're any sort
Yep.
of a practitioner.
Yep.
And then to find it's counterstrain.com to find
But
practitioners.
to find a practitioner, right? Okay. And then we do a bit of a triage. So like if you show up and you need, some of the
Yeah.
highest level work, what that local therapist does is treats everything they know. So then you may fly out to someone like myself and I'll just treat the brain part that they don't know. Do you follow me? So like they'll still treat you like, let me clear
Yeah.
everything so that the other therapists don't have to do this when you get there.
Okay, beautiful. Well,
Yeah.
thank you again for the beautiful work you've done in the world. I hope you continue, and I will just continue to share. It's very, very nice to hear your story.
Yeah, like I say, appreciate the offer. And then again, anybody out there, my email, whatever, I do try and get back to people if you have a question, or at least I can point you in a direction. But the practitioner search, for patients, if you see this, that's where you start.
Hey, everybody. I hope you enjoyed that episode with Brian Tuckey. It's so fascinating to learn more about fascial counterstrain. As I mentioned, I have someone in my office who does this, Chris Foz. If you want to know more, you can go to jillcarnahan.com and click on services and book directly with him. He's amazing. He was trained by Brian Tuckey himself, and I've experienced the benefits of that. And if you are on the go, you can listen to this on YouTube, podcast, wherever you listen to, Spotify, iTunes, you name it. Wherever you listen, would you please stop, leave us a review? Feel free to comment if you're on YouTube. I check in those messages myself and I answer. And if you haven't hit the subscribe button yet, please do hit subscribe, hit the bell so you're notified of new episodes. And we will see you again next week for another episode of Resiliency Radio.